Zeo Biologics is excited to host this webinar as a continuation of our digital education series. In today's webinar, Dr. Benjamin D'Souza will discuss the use of Kangaroo Envelope in his practice, as well as its clinical benefits leading to long-term CIED pocket health. Dr. D'Souza attended medical school at Jefferson Medical College of Thomas Jefferson University, followed by his residency and fellowship at Hospital of the University of Pennsylvania. Dr. D'Souza is currently an assistant professor of clinical medicine at Penn Presbyterian Medical Center, Perelman School of Medicine at the University of Pennsylvania, and is affiliated with several hospitals in the greater Philadelphia and New Jersey areas.
Thank you, Liz. Thank you to Zeo and everyone for attending. My name is Ben D'Souza. I'm an electrophysiologist here in Philadelphia at the University of Pennsylvania, and we're going to be talking about the Kangaroo Envelope and clinical benefits leading to long-term pocket health for our patients. So here are relevant disclosures and some of the objectives of what we're going to cover. So lots of stuff that we're going to be talking about, but this is sort of the bullet points. Common clinical scenarios of patients that would benefit from this technology. In particular, we're going to talk about device pockets, devices themselves, and appropriate health for our patients. The scope of the problem and what we're dealing with in our practice. My concerns as an electrophysiologist, so I'm a pretty busy EP doc here in Philly, do at least a couple of hundred of each type of implant every year, in addition to my ablations, and so we're going to talk about that. We're going to talk about what extracellular matrix is, or ECM, and how it applies to this and how it applies to care for our patients, and understanding how Kangaroo, which is the concept based on ECM, contributes to the overall health of our patients and who have implantable devices, the patient types that benefit most from this, and some clinical cases and case scenarios. So lots to cover, and we'll get through all of it. So this is a very common clinical scenario. These are all actual patients, things that I've seen in my own practice. So this was actually from one of my now retired colleagues, friends, father. So this essentially was a patient who needed a generator change, was referred to me, but the patient was particularly concerned about how their device was going to look. And this was something that I didn't necessarily appreciate early on in my career, certainly during fellowship, largely because we didn't follow the patients after. So, when you are out in practice and you're seeing them every few months or every few years, that longitudinal care matters, and especially for devices, which are supposed to matter through last through the life of the patient, of course. But patients actually do care what their incisions look like. They care what their device looks like. They care when people see it. And so, again, this was one of those patients that sort of reflected to me that it's important that we actually make everything look good, but also that the patient doesn't have other complications related to device implant. And so, for those who are implanters, I'm sure you already all know this, but closure of a device pocket, implantation of a device involves making sure that the generator is secured in an appropriate place with the leads that provide either pacing or defibrillation, closure of that, and to be remained that way for till we have to go back in and change the generator, hopefully 10, 12 or longer years later. And so whether you're putting this device in subcutaneous, subfascial, or submuscular implants, that is very important, again, that is done appropriately, because this is a big part of what causes infection. I think almost everyone believes that infection is introduced at the time of implant, either initial implant or at the time when you revise a lead or go in and change the generator. So that obviously is particularly important. Device infections are sort of the worst complication that we can have related to device placement. And the scope of the problem is very broad. So again, there are over 600,000 implantable devices placed in the U.S. year, whether they be pacemakers or defibrillators. And as I mentioned, infection is one of the more common and life-threatening complications that can occur with implantable devices. And so this is a picture that we never want to see. Unfortunately, all of us have had this. Certainly longer in practice, you've seen it. And I've had patients come to my clinic where their generator is literally hanging out. You can read this, the name of the device, and that's, obviously doesn't happen overnight. It happens over time. And you can see here that this sort of erosion that occurs over time. We've certainly seen patients that get this puckering of the skin. It looks kind of funny, but we don't do anything about it, at least if we don't have to. Again, I implant a large volume of devices, but I don't extract them. I'm not an extractionist. So I sort of want to avoid referring these patients to my partner who does take these devices out, if at all possible, as we all do, because I care about how my patients do. And so this is not really just a cosmetic, how does my device look problem. This is a potentially life-threatening problem as well. So as I've continued to progress in my practice and learn, as we all do, how humbling the things that we do within EPR and in particular device placement, and the many complications that can occur from device implantation. And so, and similar to ablation, but again, there's many, this list is not exhaustive, but these are just some of the many things that I have to think about when I'm implanting a device, going in to change something with a device, or putting in a new generator battery. So those can range from infection-related issues, again, abscess that could happen at where the incision is closed, the suture. We'll talk a lot during the time that we have together about capsule formation and that sort of fibrotic tissue, that avascular tissue that grows around the device in general, and why that's a concern and why it can contribute to a lot of the things we're going to be talking about. Certainly a wound opening up and the device coming out is not something that we want to see, device erosion. Hematomas, which are an increased risk factor for infection, or something also that we want to prevent if at all possible. We're doing more and more of these devices on novel anticoagulants or dual antiplatelet therapy, which can contribute, and anything to minimize that is helpful. Infections can span everything from a local abscess, a pocket abscess, to endocarditis, and pretty serious infections that are life-threatening for our patients. And we've all seen them, and unfortunately, they can be devastating. And so this is, one of the primary things we want to prevent. But there's lots of other stuff too, again, as I'm alluding to. Keloid and scar formation is not something that I readily appreciated when I started to do this, and recognized more and more that every patient is different. Certain subsets of patients are different, and there are certain patients that scar prominently, and minimizing that is really important to them because it can cause pain and discomfort, which can be chronic and very tough to treat. All of us have taken care of patients who have chronic pocket pain, and it's really miserable because there's not much we can do for them. We give them drugs, they don't work. They're constantly in the office, and we tell them that if we go back in, there's no guarantee that it'll even get better. We can extract the device, but then we have to reimplant it. They're very difficult scenarios that we want to avoid if at all possible. Twiddler syndrome, which we've seen occurs when patients play, with their device and ratchet the leads and pull back. The wires I'm going to show a couple of cases that are not that, but similar. And as I mentioned, cosmetic appearance is important. And at first I thought, only young people care about this, but I have many 80-year-olds who I take care of down in Cape May, New Jersey, who go to the beach, and they care about what their device looks like. They care about when other people see it, and it's important to them. And so that means it's important to us too. So lots of possible scenarios and things that we have to think about when we implant a device. So when I was first approached about using Kangaroo, to be honest, I was skeptical, like anyone is, of any new technology, and we get to see lots of new technology in EP, thankfully, but we have to sort of sift through the data and figure out what's important and what's not. And so I really had no idea what it was, and had to start to go back and learn more about extracellular matrix and ECM and things that I learned back in medical school, which I've subsequently forgot. I'm by no means a basic scientist, but I'll try my best to sort of reflect, what the science is behind this stuff and why it works. So we're going to talk about the components, the function, how it works to regenerate tissue and regenerative medicine as a whole, as it applies to implantable devices as well, and the promotion of healthy tissue versus unhealthy tissue, or scar formation, capsule formation, avascular tissue. So extracellular matrix, or ECM, the components are vast and largely structural, collagen being sort of the primary one that forms the extracellular matrix, which is all a part of our cells in our body. But there are multiple other factors that include proteoglycans, laminin, fibronectin, elastin, all things that are listed here. And what they essentially contribute to is a scaffold. So essentially a bioscaffold that's used for our own cells to migrate to that matrix and to either restore or repair damaged tissue. So this is a normal phenomenon in the human body. And so that extracellular matrix forms that scaffold to essentially allow tissue to bind to it and grow, but also to modulate our body's immune response. So essentially favoring constructive remodeling, the growth of healthy tissue versus an inflammatory reaction. So if you think about it, we're putting a foreign body in a patient. And so that foreign body is recognized as foreign, and the body develops inflammatory reaction in cells to that essentially grow a capsule or grow tissue around it. And all of us who have done generator changes, the first time you sort of feel that tissue, it feels very strange to you because it doesn't feel like normal tissue, especially compared to when you first put it in. And I took it for granted, sort of assumed that this was just something that happens every time we put devices in, and it's not a big deal. But it potentially is, again, the nidus for infection and the nidus for a lot of the other complications that I referred to earlier. So what is SICD, or basically this, what the device for Kangaroo pouch is made of is the submucosa from porcine or pig small intestine. So it's small intestine submucosa that essentially is the layer between the muscular and mucosal layer of the intestines of a pig, and essentially is used so that the intestine can continue to have tensile strength, but also the support as a reservoir of cytokines for growth and differentiate that tissue. So essentially this is harvested from pig submucosa, and then it's decellularized so that we can use it for clinical use. So it is truly a biologic, meaning it is from nature. It is not something that is synthetic, which is generally what we are implanting in terms of devices or using in terms of pouches for antibiotic prophylaxis. So the concept is very different in terms of how this works as opposed to other pouches. And so the concept is that it promotes regeneration of actual tissue. And the way that it does that is a difference in how the body reacts to it and the body's immune response. So M1 versus M2 macrophages, essentially a difference between stimulating fibrotic tissue, inflammation, and then potentially infection, or certainly the formation of a capsule, versus not. And so regenerating healthy tissue that is vascularized versus avascular. And that concept essentially allows the body's own immune system to act like it's normal tissue as opposed to a foreign body. So they're very different concepts in terms of how this works. And when I looked at it and I said, well, I don't really want to participate in something that's brand new for a patient when I don't know much about it. But it turns out that this application has been used in many other parts of medicine, including cardiology and cardiac surgery. And so there are over 3 million applications, but ones that are relevant certainly to cardiologists are used within cardiothoracic surgery, in particular pediatric cardiothoracic surgery, where the patient grows over time and we want that growth to continue with them, whether it be closure of pericardial tissue or reconstruction of other cardio valves and or blood vessels. In addition, burn victims benefit from this as well. So patients who have had loss of skin from third-degree burns, this technology has also been used to help them regrow tissue. So it truly is regenerative medicine. And again, you can see the other non-cardiac related use of this. So sort of the take-home point is this is not new. It's been used in many other parts of the body. So we just have recently adopted it to use it with cardiac implantable devices. So putting all that science together, how do we apply that to the use of the Kangaroo Envelope? So again, the Kangaroo Envelope is made of all the stuff that I just referred to, small intestine submucosa, or SICD, in which that product is used to promote growth of normal vascular healthy tissue and support that growth of that tissue around a generator. You can see here that these are the different sizes of the device. So they come in multiple sizes, including the only option for patients who have subcutaneous or SICDs, which we'll talk about in a little more detail moving forward. And so again, we have different options to be able to use for our patients, which we'll talk about coming up. And again, the concept is the same as it is used in different parts of the body, but that porcine extracellular matrix helps to grow vascular tissue and helps to prevent that formation of a capsule. And for certain subsets of patients, especially ones like dialysis patients, those who have felt a capsule in those patients, feel that it's harder than my countertop right here. And so it's really rock hard. It's painful, especially when we have to excise that capsule. And so preventing that from forming in the first place is sort of the concept. And in addition, the pouch itself, as I had showed you, has multiple little holes that it's very easy to throw a stitch through to be able to secure a device. And so sometimes, especially if there's lots of leads, redundant leads that are sort of hanging out in the pocket, it's difficult to be able to tie that generator down without causing any harm to it or having it positioned perfectly. Here you can really position the device however you want to, and you can use one or multiple of those holes that are within the device to suture it down, and in particular for subcutaneous defibrillators, which we're going to talk about next. And the concept is the body grows its own vascular tissue as opposed to an avascular capsule, and that promotes long-term health of the pocket and the patient. These are actual pictures taken from animal models in which device was implanted either with or without kangaroo pouch and then harvested later, and you can see the difference in terms of actual vascular tissue. And for all of us who have done a lot of this, you clearly see that capsules are, they don't have any blood vessels associated with them. And then the concept is that avascular tissue is the nicest for infection and nicest for a lot of the other stuff that we had talked about. And again, a pro-inflammatory response that occurs in patients when they are recognized by a foreign body, meaning devices and leads, which causes inflammation, fibrosis, and long-term harm, and that fibrotic capsule versus not, and forming healthy tissue. And the difference in the body's own immune response is particularly important and naturally allows for an antimicrobial response, in addition to securing the device, making sure it doesn't migrate, and making sure that the patient doesn't have that inflammatory response that can lead to pocket pain, lead to keloid formation, scar formation, and a lot of the other things that I referred to, and actually just make the device look better for the patient. So all of those things being said, who are the patients that I implant with the use of a kangaroo pouch? And to be honest, like I had said, I was always skeptical of anything that when we first adopted medicine, and I wanted to make sure that it was appropriate and safe for my patients. But after learning more about it, looking at basic science data, which there is robust amounts of, as well as preclinical and clinical data in patients and humans, as well as animal models, that decided to adopt it. But I think it's important that we bring up that the concept of how this pouch works versus a synthetic pouch and other pouches that we previously have used and currently use as well for infection prevention are that because this is a biologic pouch and because it is used to prevent a capsule formation, the patients that are best used with this are ones that are, I shouldn't say best used, but I think it's particularly helpful for de novo implants. And so that being said, implantation in patients for generator changes, the ones that are high risk of infection, there is also a benefit. I do personally try to remove the capsule in patients who come in for generator changes because we think that that's a nidus for infection, and that when we replace the generator, if we take the entire capsule out, essentially you have the same fresh pocket as when you first started. But preventing that from forming in the first place would be ideal. And so I try to take as much of the capsule out as I can and then place a kangaroo pouch in for patients who need a generator change. Elderly patients, ones that I showed that picture of earlier on, they're thin-skinned. Again, we've all seen them. You can see all of the leads. You can see the can very clearly and the outline of it. And I hate doing those generator changes because I know there's just not a lot of tissue between where I close the pocket to the air, to bacteria getting introduced into it, and where the device is. And sometimes, like this picture shows, I may not have the option to put the device deeper underneath the muscle, depending on how much lead is there. And I've inherited some patients that were implanted either elsewhere or by another doc, and unfortunately, I've had patients that come in with the generators in the armpit and they're miserable, or that they have significant pain, or that there's only this much lead and that they're dependent, and it's very frustrating. And those cases, now that I'm doing those generator changes, either on my own patients or ones that I inherited, I am particularly careful about how I do the initial implant because I'm really helping myself and my patient down the line when I have to change their battery or do a lead revision. So those skinny patients, I really wish they had a couple extra layers of tissue. And this concept is basically how we develop that, meaning develop that tissue in between the generator and the outside, where the incision is, the outside world. Obese patients are the direct opposite. Obviously, they're ones that have lots of tissue and lots of tissue that allows the can to move wherever it wants to move. And so all of us who have done these implants where you try to dissect through the plane to open up where you are going to put your generator, it just cuts right through and the can move wherever it wants. And so if that generator is not tacked down to muscle or something to keep it from moving, it's going to move, it's going to cause the patient pain and or dislodge the leads, and then you got to go back in there and fix it, which is something that we never want to do. And so I think for these patients, it's particularly important. Younger patients, they, again, of course, everyone does care about what their device looks like, but in particular, younger patients, they're going to have to live even longer with this device. And so not going into that pocket as much as possible is important, and making sure that it's healthy tissue for them long-term is important. Subcutaneous ICDs or SICDs, I think, is a no-brainer. I think that every patient should have a Kangaroo pouch who has this at a minimum. And the reason is that there's multiple, which we'll talk about in a little bit, but defibrillation threshold is particularly important for SICDs, and location, because it's not in the heart itself, is important. Now, I had a young, very sweet teacher who was in her 20s who I implanted an SICD years ago prior to my utilization of Kangaroo. And she was quite obese, so it was very difficult for me to close the incision. I spent lots of time doing it, but despite my best efforts, her generator moved. Essentially what happened was the can flipped upon itself, it pushed right up through the incision, and the wound dehisced, and I had to remove the whole thing. And I felt horrible about it, and I still remember it to this day. And those are the kind of cases that if you can do something differently to prevent that from happening, that's kind of the most important thing that we can do. And that's what I learned from. And so I wish I had this then, this was years ago, to be able to prevent that. So I think the generators are bigger for SICDs, which we all know. So you either have your really skinny patient or your really big patient, both of which would benefit from this. And, the last subset are people who are at risk for infection. And so, in particular, immunocompromised patients who have diabetes, who are undergoing chemotherapy, who have a suppressed immune system, anything to promote wound healing is important. And then dialysis patients are always at the highest risk because of the continuous, access of their bloodstream. And so I think that all these patients are potential candidates that could benefit from a Kangaroo pouch. But again, over the course of my work with these patients, I really do use these for all de novo implants because I think that it's particularly helpful. And anything I can do to minimize any of those complications I referred earlier is important to me and important to my patients. And so who do I use it in? I try to use it in everyone if at all possible. And honestly, I have a conversation with the patient. And so I think that that's important. It's not necessarily something I did before, but it's surprising to me that we'll do a lot of things for patients and not even necessarily talk to them about it. And so I think that has continued to change over time, especially as people have become more educated and have the ability to learn more about what they're getting in terms of an implant. I certainly have more sophisticated questions asked to me than ever before, which is a good thing, I think. But again, seeing that one picture on the end where patient's device is already eroded through the skin is something we never ever want to see. So anything I can do to prevent that, of course, is important for all of my patients. And so I do tend to use this pretty frequently because I think that it is particularly helpful for them. And so I'm going to go through a couple of cases next, which I think are sort of helpful that I learned from, and these are actual patients that I've seen. And so this is a patient I implanted fairly recently, who is one of my colleagues' best friend's mom. And so, he called me up personally and said, I really need you to get this patient's pacemaker in. She's like a mother to me. And I said, of course. So we brought her up. I tried to get her in as soon as possible. So I met her for the first time in the hospital. And so when she came in, we started to talk about the implant. I gave her my normal spiel about how we access the vein and et cetera, et cetera. And she interrupted me and she said, well, Dr. Ben, my scar is really important to me. And, I was a little bit surprised. She's 89 years old. And then she showed me this scar, which was just from a breast biopsy, which is, a minor surgical procedure. And she had a pretty profound scar. This is from years ago. And then she showed me around on her back from a minor dermatologic procedure that she had a huge scar from that as well. And so, and she explained to me that they're painful and they're eyesores and she doesn't like them and that she really didn't want that scar. And that was actually more important to her than anything else I talked to her about in terms of complications related to the implant, which was interesting to me, but important. And we do tend to see these patients. Again, different populations have different ways that they react and form scar. We've seen patients with huge keloids before, just from other surgical procedures or not. And I think that those patients in particular are important. And so far so good. I saw her in follow up, and her incision looks good, and everything looks good so far in terms of how the device has healed. And so the benefit that I'll see for her as well when I go and do her generator change in, hopefully 12 to 15 years, she makes it to 101, is that capsule will not form where I place the device. But in particular, she cares right now about what the scar looks like. And so another subset of patients that we see pretty frequently are thin-skinned ones. Again, pictures don't do this justice in terms of seeing the generator and the scar that you can see there, but this was another 80-year-old patient who was sent to me who had a device placed in 2012. And you can see the scar there, but again, that there is really not a lot of tissue in that area there. And so as I am doing these generator changes in patients who were implanted prior, to me becoming an attending and that I have inherited, I go into the pocket, and as I was told by one of my attendings when I was a fellow, no one says, "Ben, good job on that generator change." It's one of those just expected procedures that everything is supposed to go well. But when it doesn't, which is unfortunately more frequent than we think, that's when patients get complications, and that's when it's life-threatening. So you can clearly see the capsule here on the device. Again, while you can't feel it, obviously with this picture, all of us who do a lot of this know what that feels like, and that sort of very thick, hard tissue. I got to cut it all out, and it can be laborious and time-consuming and painful for the patient, causes bleeding. But regardless of whether you do that or not, this is clearly tissue that I'd prefer not to be there. I think all of us would. And so if I can do anything to prevent that, I think it's extremely important. So after I did a capsulectomy, then I used a kangaroo pouch. Now, something that I learned more recently from a roundtable that we participated in was that some other physicians have actually been putting the leads themselves in the kangaroo pouch, so sort of upsizing it to a bigger one, which was a concept that I didn't necessarily think of at first, but it makes sense because all of us who have had to dissect out these leads, especially if we're doing a lead revision or just need to be able to free them up for whatever purposes, spending the time to cut through that sort of tissue, that really hard tissue that's there around the device, is very time consuming and painful, and potentially dangerous if we damage the leads as well. And so the lack of that formation of that tissue is also helpful around the leads itself. And so more recently, I've been also taking all of the leads and placing them behind the generator into this kangaroo pocket as well. And I think it's been helpful, and hopefully will prevent, not so much that I'll be able to see now, but when I go back in 10 or 12 years to change the generator. So the next case is a very unfortunate one. So this was a patient that came to us at Penn Presby who was implanted elsewhere years previously and came in with a stroke. He has cardiac sarcoidosis and had a routine device check by us. He was lost to follow-up just to see if he had atrial fibrillation. But it turns out that his RV lead was not capturing. It's no surprise. You see how far it's pulled back. So you can see here that this patient had a dual chamber, dual coil ICD that, per the reports when we went back and looked, had failed DFTs, and he had failed DFTs, so had a sub-Q array implanted. Which is really unfortunate because if you see, you can tell that the generator migrated down significantly and pulled back on the leads. You can see there's practically no slack on the atrial lead, and the RV lead is pulled back to the annulus or on the other side of the annulus. And so, this patient really would have benefited from his device can not pulling all the way down, and that you know, got extra hardware and basically a non-functioning ICD. And so it's hard to tell from the picture here, but where his incision is, and you can see he's got a pretty prominent scar too, to where the actual generator is significantly further down. And in fact, just to prove the point, now this patient, when we discussed options for him, we recommended extraction, but he chose not to for his own reasons, and we ended up doing an RV lead revision. So I had the task of doing that, and you can see that my finger is sort of all the way hubbed there, and you know, this amount of distance was how far the very top of his header was from where the actual incision was. And so it's very difficult for me to reach all the way down there. I can't see necessarily what I'm doing. I'm worried about, you know, damaging his atrial lead and causing further bleeding. And so the can had migrated significantly. And I think this patient would have benefited significantly from that not happening. And so having to dig out all of this capsule formation, which again, you know, his scarring that occurred at his incision also was occurring, certainly in terms of this very thick eggshell capsule that I had to cut through and take a lot of time to remove. And again, pictures don't do it justice in terms of how difficult it was to remove all of this stuff. So certainly after I was able to spend the time doing all that, we were able to place a new RV lead. And of course, I had planned to use a Kangaroo in him after I removed his capsule, and was able to suture down the generator with the new leads in place as well, so that this doesn't happen to him again. And so this was one of those cautionary tales of how we could have prevented this from occurring if we had made some, you know, small changes to the initial implant. And so I think those are important, and I continue to learn from that as well. So this is, I'm just going to mute that. So this is the actual implant itself. For those of you who have never actually felt a Kangaroo pouch, I would recommend you do. Certainly after it's soaked in either saline or antibiotic. I tend to use the antibiotic wash that we use to wash the pocket. The feeling is particularly different as opposed to a synthetic pouch. And so it is much easier to be able to wrap around a generator and fit into a pocket that you're trying to make the incision as small as possible so that it looks as good for the patient, just in general. And so that feeling is significantly different. Now, again, this video was taken before I started to take leads and also place them into the pocket, the Kangaroo pouch rather, before putting into the pocket. But it's a lot easier. In fact, with, you know, synthetic pouches that I've used in the past, I sometimes can't even get it into the pocket. I just cut it and then I jam it in there and hope that it helps, which I'm not even sure if it does, to be honest, because that's not how it was designed. But you can see there that it fits sort of as a nice snug location for me to be able to, you know, close down and make an incision as small as possible. And this was, you know, another very thin-skinned person that doesn't have a lot of tissue, and trying to avoid you know, any issues related to after closure of the device. And so again, I would recommend that you actually feel the difference between the pouches, because you can feel the difference. And then when you actually use it in terms of implantation, it's very easy and straightforward. So SICDs, we talked a little bit about this. I think, again, this is extremely important for these patients. So the generators are larger. There is not another pocket, pouch rather, that can be used with these SICDs. And so this is really, that I know of, the only option. The anchoring is particularly important for these devices, and sometimes hard to do, especially in a very big obese patient, that amount of tissue that's there. And the importance of it being on the muscle is not just for cosmetic reasons and lead migration, but for device migration rather, but also for DFTs, and having appropriate defibrillation threshold in these devices is important. And so that's and there's more and more data coming out how important that is with these devices in particular, because they're subcutaneous and not, you know, in transvenous and in the heart itself. So I think that this is a particularly important product in use for SICDs, and I use it for every single one, because I think it definitely helps. It allows me to be able to suture the can to the muscle regardless of the orientation. I've seen some techniques where you'll put multiple sutures in to really tack it down versus just one. All options for you to be able to help to improve efficacy of the device and complications related to it. And so obviously you can see here that that use is particularly helpful in this subset of patients. So to summarize, and I'll leave enough time for questions, the Kangaroo Envelope, which again is made of extracellular matrix from pig submucosa, it helps to remodel healthy vascular tissue at the time of implantation of a device, and is meant to last, obviously, for the duration of the device and the patient. That mitigation of scar formation and capsule formation, I think, is very important, and we do believe that it is largely a nidus for infection as well as pain and other issues that we referred to. Device migration, device erosion are important and contribute to pocket pain, contribute to lead dislodgement, and to patient satisfaction. And so, again, a main difference of this device versus synthetic materials is not synthetic, it's a biologic. And so it allows the own body's natural immune response, which is antimicrobial by definition. And so that helps with the absence of putting additional foreign bodies into the patient. And again, I may not necessarily see the benefit of this, of a Kangaroo pouch, till I come back 10 to 12 years later and do the generator change. But now doing more and more of those, I respect how much that the simple things that are done at the time of an implant will make my life and the patient's life easier in the future. The pliability and ease of handling is significantly different. If you feel it, you'll know what I'm talking about. Certainly, I would encourage you all to do so. And then the last part is that, in my previous use of the device, I think that the shelf life is important. We're always trying to make sure that we don't put products on the shelves that expire. The changes in size are important, so that any device type, size, putting the leads into it or not, use with SICD are important considerations as well. And sort of putting all of those things together, I think, is important, so that we can do the best for our patients and make sure that we minimize complications and make sure that we do everything we can to make them happy. And certainly for our patients who have chronic devices and have had the issues related to them, we all know those patients. We can think of them. I'm like, oh, so-and-so's coming back into the office again. And I have nothing to offer them. And that's very difficult clinical scenarios that, if I could avoid, if all possible, I'm doing the best for myself and for my patients. So I'll leave it there for questions, and happy to answer anything at all.
Awesome. Thank you so much, Dr. D'Souza. So just to remind everyone one more time, if you have a question, please go ahead and use the text to chat feature at the top right-hand corner of your screen, and we can address your questions. But I'll go ahead and start off with a couple that came in. So, initially, what made you start using the Kangaroo? And if, there are 1 to 2 key features that really drove you to begin using it exclusively, what were they?
Yeah, so it's a good question, Liz. So, my previous usage of a synthetic pouch was in general only for high-risk patients or generator changes. But what I found at the time was that the shelf life would expire, and that the device, that pouch, was either not on the shelves, or I was using it in patients I hadn't planned on using it. So sort of frustrated from that standpoint. And so when I was initially approached by my Boston Scientific rep, who introduced me to my my Kangaroo rep, was that this was a potential option for patients. And again, as it's cited, for subcutaneous ICDs, they didn't really have any option for those patients, and thought that those were the highest risk of device migration. And so started using those patients, and then builded towards that. But then found, again, as I'd mentioned, those clinical scenarios where I get patients that are coming in with device migration or the worst, device erosion or infection, really drove me to want to do the best that I can for my patients. And so had conversations with them and discussed the technology and discussed whether they thought it was something that they would want. And almost universally, patients said, yes, of course, I want something like that to prevent all the things you're referring to, and now adopt it for essentially all of my de novo implants.
Okay, great, thank you. We will kick it to one question that just came in. What do you think of subpectoral pockets, and can we use the pouch in this application?
Yeah, it's a good question. And so again, submuscular pockets, whether they be for a transvenous device or for a subcutaneous device. So more and more, some folks are putting under the serratus muscle. And so you certainly can, and I do use this pouch for that as well for a couple of reasons, in addition to sort of what we had referenced. But I think that it certainly helps with keeping, you tend to get less device migration with submuscular pockets as well, but the same concept applies, meaning the lack of formation of that tissue that occurs, capsule and or device erosion migration. I do believe that it will likely help with bleeding as well, because again, that growth of normal tissue as well. And so I think I do use it for submuscular as well as for the ones that are placed within the fascia itself. I think the same concept holds in terms of preventing that formation of the capsule, fibrotic tissue, and for antimicrobial response as well.
Okay, great, thank you. So for generator changes, do you typically cut on the same scar or make a new incision?
Yeah, that's a good question. In general, I try to use the same incision that the patient has had. Sometimes we're limited because the can has already migrated significantly, and especially if we need to put a new lead in it, depending on what vascular access options are. I typically will use the same scar as what was used before for cosmetic appearances. Sometimes that's not an option. And so the scar that's already formed is a scar that's already formed. And so a lot of the stuff that's already happened to the patient, we can't prevent once it's already happened. And so that's why I think it's important to minimize that from the beginning as opposed to in the future. But I do tend to use the same incision again. But again, for those of us who've done that and feel that area of that tissue, I think it's also important for those patients to minimize further scar formation or worsening of healing in those patients.
Okay, thank you. So back to the capsule, how do you feel that this impacts the long-term health of the pocket and your future interventions?
Yeah, so as I had mentioned earlier, I had just assumed that capsule formation was just something that happened with all device implants, and that it's something that you can't prevent, and it is what it is. And didn't necessarily excise capsule or do capsulectomy on all my patients, but I think more and more I've moved towards that because I do think that it helps. The question is to whether the use of a kangaroo pouch in patients who already have a capsule. I believe that it's most likely best if that there isn't a capsule there in the first place, because that avascular tissue is already grown. That being said, further promotion of that avascular tissue or capsule is still important, and I do believe that histopathologically using a kangaroo pouch in those patients is still helpful. That being said, my personal approach is to remove the capsule if at all possible, or as much of it as I can, because I think that's the source and the nidus of infection. And so I again try to not form in the first place by using a kangaroo pouch. If a patient is getting a generator change and already has one, I try to dissect out as much of it as possible and use the pouch. And if I can't for whatever reasons, then I'll still use the pouch to prevent further capsule and scar formation.
Okay, perfect, thank you. And so I think this is along the same lines, but this individual really likes the idea of removing the fibrous tissue around the leads. So just wanted to know if you run into seeing any issues damaging the leads during revision.
Yeah, during revisions or during generator changes. Yes, for all of us that have had to do this, I'm not an extractionist, but my colleagues who do, they have to labor through the amount of time it takes to remove these leads. But for me in particular, who's trying to get in and out without causing any harm or damage to the previously implanted leads, it's particularly important. And that's why when I had heard the concept of putting in the actual leads itself into the pouch, I thought that was very smart. And so I think that's why things like this, in which we interact with each other and we learn more from each other, are particularly important, especially in a post-COVID world where we don't have the ability to gather. And so I heard another physician during the roundtable we recently did mention that, and I said, oh, that's a really good idea. I'm going to try doing that. And so change my practice towards doing that as well. And so there is definitely concern, and I'm always concerned, even with the use of, not Bovie, but other techniques that may help to minimize damage, using a plasma blade or a photon blade to prevent that. Still, I'm worried about those leads. The patient who's pacemaker dependent with no underlying, who I'm cutting down around these leads to get all of this scar tissue out so that I can free up the lead to change a generator. I'm not thrilled about doing that stuff because, God forbid, if I cause any harm, it's life-threatening. The patient will die. And so I think all of that stuff is important. It's really not just cosmetic appearance. These are potential life-threatening complications we're talking about.
Right, thank you. Okay, so very last question here. We know that everything you add to a case potentially has financial implications. So how did you overcome that, if you were faced with any pushback?
Yeah, that's a good question. So, when we initially had discussed, using this product at Penn Presbyterian, certainly financial discussions have always come up, and they always, even in a post-COVID world when a lot of hospitals have lost money and suffered, it's gotten even worse. And so really when the conversation comes down to, what's best for the patient, what's best to prevent complications, including, device erosion and need for extraction and the hospitalizations that have occurred based on those things, then it ends up being an easier discussion in terms of safety, efficacy, lack of readmissions to the hospital. Those tend to weigh. Those are things that administrators and people who approve this type of device tend to hear. And so, not just the quantity of procedures that we do, but the quality of procedures that we do is becoming more and more important over these years. People are looking at outcomes, they're looking at complications, they're looking at not reimbursing hospitals and physicians if things occur within a certain amount of time. That's already in place and it's going to continue to grow. And so really this pushes the burden upon us to make sure that the things that we're doing the first time are safe and appropriate. And this fits perfectly in with that. And so really did not receive much pushback in terms of being able to use the device when you're able to understand the benefits of it, the science behind it, and that you can prevent further complications, which those downstream complications actually cost significantly more. And so if you look at it that way and present it that way, it's really not a hard sell, so to speak.